recognize Representative Kelly for her 5 minutes of questions.
Thank you, Madam Chair, and Ranking Member DeGette for holding today's hearing, and thank you to all the witnesses. It is important that we do not ignore how in this last week, Secretary Robert F. Kennedy Jr. and others in the Trump administration continue to undermine Congress and the public health system's ability to function cohesively with the firing of senior staff and experts. Secretary Kennedy is putting Americans' health and well-being at risk by actively disseminating HHS. Unfortunately, too many of my HHS. Unfortunately, too many of my colleagues remain silent on this devastating public health issue and other harmful policies caused by the big ugly bill. But our work continues, and that's why I'm proud to co-chair the bipartisan Digital Health Caucus with my colleague, Rep. Troy Balderson. I encourage my colleagues on both sides to join us as we aim to educate and learn more about these issues. The integration of AI in the healthcare system offers a potential to be a transformative solution to address longstanding disparities and access issues, as you guys have talked about. Many in both the healthcare and technology fields have promoted AI to create a more accessible and equitable healthcare landscape, particularly in minority, underserved, and rural communities. However, we must remain vigilant of the promises as well as the limitations. Dr. Mello, AI tools are only as good as the data they're built on. When the data is incomplete or skewed, the results may lead to inaccurate suppositions. We've already seen examples where algorithms underestimated the needs of Black patients because healthcare costs were used as a stand-in for health status, and where dermatology tools trained mostly on lighter skin tones misdiagnosed conditions on darker skin. These cases show how quickly AI can replicate the inequities already in our healthcare system. What steps should developers, health systems, and federal regulators take to make sure AI tools are tested on and validated for diverse populations before they're deployed?
It's such an important question, and I know you've heard already about the need for large data sets that include sufficient representation from a variety of subgroups, including, I'll add, subgroups that are not usually on the map for anti-discrimination worries, like kids, people in rural areas, people with rare conditions. And FDA, of course, should be doing more in the area of performance testing. But let me add a wrinkle that I think doesn't get talked about enough, and that is that even when you have a well-performing algorithm that performs well for all of those subgroups, bias and inequities arise at the point of care because of the way that it's deployed. And I'll give this a simple example. We've got tons of algorithms at Stanford that screen our patients using information in their medical record to identify people who would benefit from additional services. But our ability to get those patients in the door is dramatically different depending on what those patients look like and where they live. So unless we're willing to spend more money doing outreach and creating more capacity in our clinics for those patients, they can benefit in theory, but not in reality.
Interesting you say that. As chair of the Digital Health Caucus, or co-chair, one of the things I'm looking to better understand is how AI and data science can help with efforts such as clinical trial recruitment and retention. I'm also chair of the Congressional Black Caucus Health Brain Trust. What are some ways AI can be used to get more people into clinical trials? And what ethical or policy guardrails should Congress consider as we support this responsible use?
Well, I think the main area where AI can help is in the identification of potentially eligible patients. We heard already about the NIH initiative. At Stanford, we have a new tool being deployed across our system now that enables a researcher to query the medical record to find all patients who have a particular health condition and meet other inclusion criteria for the trial, and that could be hugely helpful. I will say, though, that a major reason why we don't have representation in clinical trials is not that we can't identify the patients, it's that we can't convince them to enroll. And AI is never going to get us there. That's where we really need the human touch, reaching out to those communities and explaining the benefits of trial participation along with the risks.
And my office has been doing a lot of work around that because we know all the past issues that people have and the lack of trust, but we know there's still a lot more work to do. Thank all of you so much, and I yield back.